Right on, guys. I haven't done a video in a long time. Nothing really to talk about. Those who've been following my videos know I've been waiting up Bristol for bladder augmentation for just over 2 years. I had a disastrous consultation back in October with an MDT letter basically discharged me back to Trelisk. They've insisted I was dragged up there for video urodynamics, which Matt Otchin suggested I have done 2 years ago, but Bristol felt weren't necessary at the time, so we're going to talk about video urodynamics today. It's very similar to my previous video on urodynamics, but obviously we'll go into the depths of video urodynamics. So urodynamic testing basically tests flows, pressures in your bladder, abdominal and the detrusor to see if they can identify what the problems are basically. With video, this is done with x-rays, is what we're focusing on today. So when you get your letter through in the post, it will tell you to stop taking various bladder medications, mirabegron, sulfenacin, oxybutynin. I think tamsulosin was on there. I was lucky I didn't, because I can't pee normally. I wasn't told to stop taking tamsulosin. If I'd had, I wouldn't be able to get Bristol. Her meds like sorpameto aren't on the list. That list isn't exhausted. There were other meds, I just can't remember what they are. So you'll be asked to stop taking these a week before. Things like mirabegron and sulfenacin have a 10 to 15 day washout period. So it's unlikely your symptoms will return within the 7 days. Tamsulosin, on the other hand, has a washout period of 12 to 24 hours, is why I can't come off it. Obviously, it depends on what you're taking it for, really, at the end of the day. Mine was obviously to help relax and soothe lower urinary tract symptoms. Most men are on it to just try help and pee. Even on the tamsulosin, I can't move a drop. So they dragged me up to Bristol yesterday, 8:30 start. They were late starting at 10:09. I saw Mr. Sharaf, who I saw in October. He's one of the functional urologists up there at Southmead Hospital. We had a quick consultation. I took a bladder diary with me, questionnaires. I had my original copy of urodynamics from Trelisk back in 21. Basically discussed what we were expecting to get out of the test. They left me in the room to change into a gown, everything from the waist off, including your socks, similar to before. On a bed. This time it was more of a urology bed, so cut out at the bottom with stirrups, but obviously being male, everything's easily accessible. Obviously if you were female, you'd probably be put up in stirrups. The only one of the major differences to this test, they ran what they call a sphincter test. You initially had a tube cath, so it had the balloon up your bum, the fine cath in your bladder. The sphincter test is a bit uncomfortable. Obviously, I self-catheterise, so having anything up in the bladder is not an issue. It's a bit of a pain because they put a catheter in, a machine calls it back. They put the catheter back in, a machine calls it back. They do this 2 or 3 times, and basically it tests whether your bladder sphincter is weak, whether it's strong, whether it's overzealous. Mine was tested normal, so that part of the test was done. They then put a fill cath, which is about 6, 8 French, something like that. The test cath is like a 1 mil wire. It's very, very fine. Again, it's uncomfortable when they're pushing it up in, but no, again, I'm used to cathing. Even when I had the test done originally, it was a bit painful when it went in, but it wasn't uncomfortable. Obviously, if you can pee normally, you'll be asked to perform a flow test maybe once or twice prior to the video urodynamics on the same day. Of course, because I can't pee normally, I made it clear in my notes and in my letters and emails that obviously there'd be no point performing a flow test. I literally emptied my bladder with a cath minutes before I went in to have the video urodynamics done. So basically the bladder was bone dry. They didn't do a PVR test. Normally, like when I have my standard urodynamics done at Trelisk, they did a PVR test to test what your baseline residue is. Sometimes they might drain it, sometimes they won't. Some letters say they will. So again, some hospitals went. It didn't at Trelisk. They use that as a baseline for your fill. They then fill you with a iodine based solution. It's clear, but there's iodine in it, and this is how they visualize your bladder during the video urodynamics. Basically, I was worried it would cause a flare. I was assured by Sasha Mould in London it doesn't. I haven't had any issues. I can only go from my experience. Not to say everyone won't flare from it, but the consensus is it shouldn't cause a flare. I know some people flare from next to nothing, so you have to take that chance or choice if you're offered the test. So obviously after all the catheters were put in, is a little bit of time you're exposed in the same way you are when you're having installation done, sterile sheet, your tackles are hanging through it. It's only the urologist and the urology nurse. I did have a medical student sitting in with me, but she was sitting back behind my head, so to all intents and purposes, she could only see what was on the screen. She wasn't there gawking, which you wouldn't really expect anyway. The nurse handled their test part of it, and the urologist sat back and watched the screens from afar. Once all the catheters were in, I was asked to stand over a flow meter. Again, your gown is draped, so everything's covered up, and they have what looks like a round magnet, basically, with a slot in the middle. They position that front to back, level your pelvis. They'll do a test x-ray to check it's at the right height. You might tip it and might lift or lower it. And then obviously they instill the liquid into your bladder and take periodic x-rays which show up on a screen. And this is why they call it video dynamics. It's not a video as you would see a scope, but it's, it gives two specs to it. They got their printouts on the graphs and obviously the x-rays at the same time. So they filled the bladder quietly, and it's going in at something like 50 mils a minute, so it's very, very slow. And there's a counter on the screen sort of thing, and they said, tell us when you get to sensation. So I think about 100. I've been passing about 150 awake generally during the day. So I got to about 120, and I said, yeah, I could do. I'll be looking to go for a pee now. Got to 150. I said, yeah, that's comfortable. There's no urgency, although we're right on the end of the Botox. We're well over 12 weeks now. We got to 200, which I have passed recently if I've been sitting quiet over dinner time or at home in the evening, and it was a strong urge to pee. No, we still was no urgency, but it was at that point I was saying, look, if I was at home, I'd be wanting to go for a pee now. You can still defer it now at the end of the day. So they said, oh, we must push you as far as we can to see, get the data. I said, oh, all right. So they went to 250, and I said, oh, that's getting, yeah, I'd be wherever I was to by now. I'd have to go. It didn't matter being in the back of the van, side of the road, breaking the door down somebody's toilet to get in there, sort of thing. No, he was. No, I have been only passing 250 overnight. I've passed up 300 overnight recently, but generally it's about 250, 300 overnight. So we're well over now what I was ever going to hold awake. And again, the data was showing, they were testing poor compliance. That's why I was having the test, because they felt that Trillis data didn't show a poorly compliant bladder. And unfortunately, the data was reading no differently. And they said, well, your bladder's still not fully inflated. So they said, can we go a bit more? I said, all right, go a little bit more. We got to about 282. And I said, look, you're going to have to stop. No, I said, it isn't a battle of the wills. And the data wasn't showing nothing. No, if they said, look, no, we're seeing clear data that supports poorly compliant bladder, I would have maybe said go to 300 sort of thing. No, and back before Christmas, there were odd occasions if I was really breaking my neck for a piss, come home from somewhere or been stuck on the phone to somebody. I had occasionally passed 300 awake, but generally going on, it tends to be 2 to 225 awake. No, I don't need anything to pass 300. So we were well over what I'd ever hold awake, and I literally couldn't move off the spot. It wasn't painful. There was, I suppose, a tad of urgency there, and it's very easy for them to put words in your mouth. No, I said, at the end of the day, there's a strong urge to pee. Urgency, there's a fine line between urgency and a strong urge to pee, and I think once you start developing bladder problems, they are quick enough to say, oh, well, you got a strong urge to pee, it's got to be urgent. And even in a normal bladder, you will have a fill point, and a lot of people can defer that. They can ignore it, it'll go away, and they might hold another 100, 150, by which point it then gets urgent. So normal people can still get urgency, but they can defer going for a pee, which obviously I can. I can only defer going so long. And this was at a point where I wouldn't have been able to defer it. Doesn't matter how you could sat there and waited for an hour, and it wasn't going to defer going for a pee. And I said, look, I've had enough. I said, at the end of the day, I said, data isn't showing what we wanted to show. I said, I'm not going to be subjected to any more of this. So they were quite happy at that point. Took the last of the x-rays. They collected all the data on the screens. They said, well, can you try going for a pee? So now I got my gown lifted up, tackle hanging out in the flow test. Again, it's only the nurse that can see it, and they've seen them all before. And I said, no, I got more than most, but unless you're sort of got something that's halfway down your thigh, they're not really going to care at the end of the day. They said, can you try? And I was like, real straining. No, too shaking. They said, oh, no, don't strain. I said, well, barely move a trickle. One, if I'm straining, I have a bowel movement. This is sitting down. Mind you, I was standing up. Test was done standing up. Obviously, if you weren't capable of standing, you would be done with it sitting or lying down, I would imagine. But generally going on, if you can stand, you expect to stand for the test. I didn't at Trelisk. The only time I stood at Trelisk was to do the flow test after the urodynamics itself. And then they said, try and relax, because you're there sort of trying to relax, trying to think of other things. And I said, it's no point. I said, I'm here cathing 12 times a day, and I've done for just over 2 years now. I said, I wouldn't be cathing 12 times a day if I could pee normally. Some people can pee normally. They'll pee to an extent with high PVR, and that's why they'll cath. They'll cath 1, 2, 3 times a day to get rid of excessive PVR, but they can still pee normally. So it's not critical that they have cath with them. They may not even carry a cast on them at all if they can pee normally. But I literally cannot move a drop, even on a tamsulosin and a saw palmetto. So we just want to take the sensors out. They collated all the data, and I just had one of my catheters, slipped it in, emptied into the flow meter. Again, they're not measuring nothing now. Obviously, if you could pee normally, this would obviously then record your flow and the pressures. You know, when I did my urodynamics at Trelisk, I had to pee past the sensor, which is not easy, and I ended up pushing it out, which is always a risk, really, because obviously they take the fill catheter out, and obviously just leave the fine sensor catheter in there. But again, I found in my original urodynamics, I actually pushed it out my bladder, straining to pee, because obviously the rectal pressure was high and the abdominal detrusor pressure was low in my previous urodynamics, which is what indicated to Trelisk that the bladder was poorly compliant. And then you were left to clean up, give them some towels to wipe your ass off. They took them towels to wipe your ass off with, because obviously there's a lot of lube where they put the balloon up in. Worst part was taking the tape off my ass, because I wasn't quite hairy, so that was worth it. Taking the tape off me legs and off me cock. You'll have to get changed behind, and then they come back and consultation out of the results. I didn't bother asking for the results. They'd probably be sent to Matt Otchin and Trelisk. I've seen all the x-rays. No, they said that the bladder's not fully inflating at 282, which would obviously reinforce what I said originally, is that I didn't naturally have an anatomically small capacity. If they were doing this, say, on a child, which they suspected as having underdeveloped bladder, then at the point that they'd had enough, the bladder will probably be showing fully inflated. And then this is then where they're at a point really where do they operate with such a bladder augmentation to make the bladder anatomically what it should be, or like they did with my cousin, second cousin. They gave him medication and time forwarding, and they did naturally stretch it to what it should be. But they could see the bladder wasn't fully inflated, so we're not. Reinforces what I said originally, is that prior to IC I had a 450-500 ml capacity, and the lack of fully inflation of the bladder enforces that it could have taken another 250. But what we found on the general anaesthetic, which I mentioned in the previous videos, my bladder was originally rigid at 350 to 400 mils on the general anaesthetic, supposed to take 1,000 mils. It has subsequently done other figures, higher or lower. We tend to stick under 350 now, because over that I end up with pain on waking, prolonged pain for days, bleeding either during or for days after, and sort of stretches over 500 mil. It actually makes the capacity worse. Obviously, they felt the bladder's got compliance, which is extremely hard to believe, because I can't pee normally. Well, before Botox, I had a flow that was down to about 5 mils a second. The general anaesthetics have shown that the bladder is poorly compliant, is rigid, stiff, whatever you want to call it, really. The Botox has made it more pliable under general anaesthetic, but it's not made any difference of weight. It gets rid of the urgency, or controls the urgency, but nothing more at the end of the day. Yes, that's video urodynamics, really. This is a little bit different to standard urodynamics. Obviously, you have to go to a specialist hospital. I think I was told they do it in Derriford now, which is our next main hospital outside of Cornwall, but obviously it would have been on a different consultant and a different referral, and they don't do reconstructive pelvic surgery at Derriford anyway. So if you were being referred on the basis of reconstructive pelvic surgery, then you need to go to the hospital such as South Meadle guys where they do the operation in order to have the video urodynamics there. Yes, that's that really, guys. And obviously, the outcome of that, basically, they think it's all in my head. They think the sensory urgency, which, if that was the case, no, my bladder would take 1,000 mils under general anaesthetic, and no, I could get away with a 400 or 500 mil capacity for weeks, months, until such a point I needed another hydrostension and on we would go again. But it's not the case. And they said, oh yeah, bladder training for a month to sort you out. Well, what do you think I've been doing the last 4 years? At the end of the day, no. If it was that simple, I wouldn't have been referred for surgery. But that's where we're to, guys. So I hope this video helps if you are expecting urodynamics. So again, nothing to panic over. It's a bit embarrassing, but like everything, it's not a battle of the wills. Go to wherever you feel comfortable. As long as they've got the data they want, that's it. Well done, guys. Cheers and bye.